Welcome to this short talk about contact tracing. I'm Mike Crilly, and this third section is going to focus on the public health approach to contact tracing as a method of controlling and containing COVID. So contact tracing is an organised approach in responding to new cases of COVID, to notified cases of COVID. So the usual approach is for the laboratory, when they have a positive test result on a swab, on a nose and throat swab, is to inform public health that we have a case of COVID. So we need to interview that case in quite a lot of detail and depth to identify who else may have potentially been exposed to the virus, to potential contacts. And then we seek to speak to those contacts by phone. So that contacting them provides an opportunity to reinforce appropriate public health advice about how to prevent the spread of COVID. So hand washing, not touching your face, catching sneezes and coughs in disposable tissues. So we can reinforce that advice. If we discover that the contact is a close contact, so they've been within 2 meters of the case for 15 minutes or more, then we advise them to self-isolate. We ask them about whether they have any symptoms that may be related to COVID, and if the case, if the contact reports that they have symptoms, then we can offer them testing, and if they test positive, then they themselves become a case. So the contact who tests positive then becomes a case, and the whole thing starts again. We start looking for additional contacts they may have had. This is the stone in the pond way of thinking about risk assessment. So we can think about a still piece of water in a pond, and if you toss a stone or a pebble in, it causes a splash, and ripples and waves spread out from the centre, and as it spreads out, the waves and the ripples become smaller as they move further away. So at the centre, where the stone hits the pond, we have the case, and immediately the wave around that case are the people who are high risk, and these are the close contacts, those individuals who share a bed with them or who spend 15 minutes or more within 2 meters of them, so household contacts, for example. So they're the high risk individuals. There are medium risk individuals. These are the contacts who spend some amount of time with the case, but they're at lower risk. And then we have the very low risk individuals. So they're the contacts who spent a minimal amount of time, just a very casual contact with a case. So in relation to the risk of somebody having acquired infection with the coronavirus, with a case of that disease, is that the closer the contact, the higher the risk is of acquiring it. The approach in Scotland is one of test, trace, isolate and support. So the simple flow diagram here starts with a person experiencing symptoms such as cough or fever, headaches, fatigue, that we think are consistent with COVID, and they're advised to self-isolate. And that initial assessment can be undertaken by phone or potentially online, and testing can be arranged to see if these symptoms are being caused or a result of being infected with the coronavirus. So we can start to ask about close contacts and identify close contacts. When the test comes back, if the test result is negative, then that person hasn't got coronavirus. They no longer need to self-isolate, and we don't need to trace any more of their contacts. But if the person tests positive for coronavirus, if the PCR test is positive, then we need to contact trace all the close contacts and support them in self-isolating for 14 days. So this requires us to be able to do quite a lot of things very quickly. We need early and rapid availability of testing, so we can test symptomatic cases who are possible cases of COVID. So we can advise them to self-isolate. We get the test. If the test is positive, they need to continue with the self-isolation. We chase the contacts. If the test is negative, then they can return to their normal activities, and we don't need to chase the contacts. We need to be able to do early and rapid tracing of the close contacts, because they also need to be advised to self-isolate. We need to be offered early and rapid PCR testing to the close contacts who either have symptoms when we contact them or possibly develop symptoms during the 14 days of isolation. And because some people during 14 days isolation may develop no symptoms, some individuals may face a scenario they actually have to isolate for 14 days on more than one occasion. So there are some factors that are likely to increase the spread of COVID. Direct personal contact with someone who has COVID, a COVID case, for example, sharing the same bed. Close or longer contact with a COVID case, so being within 2 meters for 15 minutes or more. Having frequent contact with someone with COVID cases. So, for example, the scenario of the bus driver who probably isn't having 15 minutes of contact with individuals, but has short, brief contacts with lots and lots of individuals during the working day, and may be exposed multiple times, but for short periods of time to individuals with COVID. People with poor hygiene etiquette regarding coughing and sneezing, so they don't cover their mouths when they're coughing and sneezing, don't use tissues, and people who have poor hand hygiene as well and not frequently washing their hands during the day are also much more likely to spread COVID. The infectiousness of the person who has COVID, so for example somebody who has coughing fits and is coughing and spluttering around other people, is much more likely to spread COVID than someone whose major symptoms, for example, are headaches and fatigue. So the symptoms the person has with COVID influence how readily it can be spread. And then finally the environmental situation, so in enclosed small indoor areas, it's much easier for COVID to spread in the airspace than, for example, outdoors. This is an illustration of the self-isolation involved when there's an index case in a household. So we need to take into consideration the incubation period of the coronavirus, and that's the time from initial exposure that an individual has to the virus to the onset of their symptoms. And the best available evidence suggests that the incubation period averages about 5 days, but has quite a wide range around that, between 1 to 14 days. So we tend to use 7 days as the unit because it's quite a familiar period of time. It makes it easy to calculate the end of isolation dates. We just need to bear in mind that guidance and policy can change, but at the moment we advise cases to self-isolate for 7 days. So a case in a household would be advised to isolate for 7 days, and the household contacts, so people sharing the household, by definition they're going to be within 2 meters for more than 15 minutes with the case. They're close contacts, they're advised to isolate for 14 days. So we can see the scenario on the right of 4 individuals sharing the same household. We have an index case who gets unwell on day 1, and that triggers their 7-day isolation. They become unwell, they test positive, they're in isolation for 7 days, but it means that the rest of her family are in isolation for 14 days. So for the index case, after 7 days of self-isolation, provided they'd been free of fever for 2 days, for 48 hours, then on day 8 they can come out of self-isolation. Some of the symptoms, for example, a cough, can last well beyond 7 days. So people are able to come out of self-isolation if they still have a continuing cough, but not if on day 6 or day 7 they experience a fever. So in this scenario, the second person in the household is initially told they'll be isolated for 14 days, but on day 3 they become unwell with symptoms of COVID. So that starts 7 days of isolation for them, and they can come out of isolation provided they're free of fever on day 10. We can see the third individual develops no symptoms whilst at home. So they self-isolate in the household for 14 days and come out of isolation on day 15. And you can see the fourth individual gets up to day 12, but then on day 13 becomes unwell with symptoms suggestive of COVID, and so that restarts the clock for them, and they have another 7 days of isolation, and it won't be until day 20, provided they're free of fever, that they can actually come out of isolation. And within the household, the people within the household should also be trying to keep at least 2 meters away from other people in the household, and following the usual hygiene etiquette, disinfecting surfaces, taps, and door handles. And at the bottom you can see just a reminder that people may also be able to pass on the coronavirus even when they're not showing symptoms. So in questioning someone who's got COVID, a case of COVID, we need to focus on the case's infectious period, and this means taking account of the fact that people can be infected with the virus and be asymptomatic, not have symptoms up to 2 days before the symptoms start. So we need to ask them about their contacts starting 2 days before the symptoms began. And the things we want to inquire about a new case of COVID, about the places where they spent time, the persons with whom they spent that time, and participation activities and events, the what and the when. So it's the where, the whom, the what and the when. In lockdown, it'll be much more straightforward because it will just be the other members of the household. But as lockdown is eased, the range of contacts, the places people have been, the people they've interacted with, the activities and events they've taken part with will become much broader. One of the key aspects is to check what people do for a living, what their job, what it involves exactly, particularly a concern if their job involves contact with vulnerable people. So somebody who says, I work at the cancer unit at the hospital, where people may be treated with drugs that suppress the immune system, well, we'd have great concern if that person is working on reception and welcoming all the new patients. We might be less concerned if the person has an office administrative role in the back office and has no contact with patients. So it can be quite important to find out exactly what somebody's job involves, and particularly who they may have been at risk of spreading the virus to. So who are the potential contacts of somebody with COVID? So the contacts are people who've shared a space and an airspace with the person, the case, who has active COVID. And you can see the diagram on the right. You have the case, and predominantly their contacts will fall into one of three groups. Their household and residential links and contacts, the people they work with, and also their leisure and recreation activities. So we're primarily thinking about household members, other members of the family, friends, fellow workers, and also other settings, so residential accommodation, care homes, nursing homes, churches, day centres, and people in prison, their cellmates. So the contact tracing itself is extremely resource and time intensive. We think that probably the duration of phone interviews with a case can be anywhere between 45 minutes to 1 hour, and with contact can be somewhere between 5 to 20 minutes on average. During lockdown, each case generates somewhere in the region of 3 further contacts, close contacts, whereas with lockdown, it's likely that each case will generate somewhere between 7 to 20 contacts. And contact tracing, unfortunately, is not a perfect science. It involves dealing with members of the general public, with their concerns and anxieties, with the related issues of poor recall of events and who they've had contact with inconsistent information, and often if you gather information from the same person more than once, you find that the information also changes over time. So as people think about what you've asked them, if you then ring back to check things, you sometimes find that the story changes over time. And we also have the frustrations of having uncontactable individuals So contacts whose mobile phone goes to voicemail every time, and also people who we keep hearing about who've been in contact with the case but nobody knows who they are, so the unidentified contacts. In interviewing cases and contacts, it's important to start off by explaining who you are and why you were calling, that the purpose is to gather information and to confirm information that you may have already received. You need to try to be non-judgmental about people, about how they've behaved and what they've done. It's important to have an empathetic approach so that you can establish on the phone a rapport with people. And it's generally much better to start off with open questions such as how have you been feeling recently, have you been unwell, rather than closed questions such as have you had a fever, yes or no, have you had a cough, yes, no. It generally works much better in obtaining information if you start off with quite open, broad questions that people can respond to before asking very closed questions where the response is just a simple yes or a no. You may need to gently redirect people if they start to go off track, and you need also to probe some issues, but without actually leading people so that they give you the answers that they think you want to hear. It's important at the end of the interview on the phone to thank them for helping you, and it's often very useful to ask if anything important has been missed out, because having chatted with someone for a while, it often provokes thoughts, and it's often very useful, and you can often get very useful information if you ask the person, is there anything important that we've missed out? You need to ensure that they understand how to seek further help and advice and information, and then it's often helpful to end with asking them, is there anything else that they want to ask you before closing the interview. So interviewing cases and contacts, the public will generally be unaware of what contact tracing involves. They'll be unfamiliar with the approach. It won't always follow the script, so there will be scripts available for contact tracing, but as you become more experienced, they just become a crutch or a crib to refer to briefly. Don't worry if the interview doesn't always go perfectly. It's a two-way process, so you're not always in control of it, and it's quite important to develop your own personal style. So a wide variety of people have very effective contact tracing skills, but they have very different approaches. It's important to direct people to useful sources of additional information, such as NHS Inform, and be prepared to admit that you don't know the answer. You can suggest that they might find the answer on NHS Inform, or they may well be asking questions to which nobody has any answers to at the moment. And an important issue is respecting confidentiality. So it's important that we respect confidentiality, and challenges can arise with confidentiality in relation to contact tracing. Basically, cases have a right to expect confidentiality and privacy. But when you approach the contacts and inform them that they've been exposed to COVID, you won't necessarily be able to tell them who gave the contact name to them. So it's important to disclose only the minimum amount of information that's required for contact tracing to contacts, unless the case is explicitly given permission to tell their contacts, and that will often be the situation. So you'll speak with somebody who was tested positive for COVID. They're quite happy to look at their diary or their mobile phone or their contacts on their mobile phone, and tell you the names of all the people they've had recent contact with and their contact numbers. And also, if you ask, is it okay if I tell these contacts that it was you that gave me their names? Most people will be fine and will say, yes, that's fine. But you need to be very careful if people don't want their information shared, don't want it shared, that they were the index case, they were the initial person who's tested positive, then it's very important that you respect that. So the difficult conversations in relation to contact tracing, some of these we've already alluded to. It's going to be very frustrating when the mobile phone of a contact repeatedly goes to answer phone. You will find some people are quite suspicious when you contact them by phone, and we want to know how you got their details, how you found out about them, who gave you their mobile number. You'll be dealing with concerned and anxious individuals, with individuals maybe sometimes who are too unwell to speak, for example because they're in intensive care or very unwell, in which instance you may need to speak to the next of kin, to relatives, to get the story. As we've suggested, a quite common question might be, who gave it to me, who did I catch it from? So you may need to respond to that. And also health related questions, should I stop my steroid tablets? Well, that's not a question that can be answered through contact tracing, and the advice would be to contact either the specialist looking after them or their general practitioner, their GP. It can be frustrating, but you'll have some individuals who refuse to self-isolate, won't take the advice, decline to be tested despite the fact they've got symptoms, or even plan to continue working. And finally, I think I can say this as a bloke, men traditionally are notoriously poor historians, so it could be much more difficult to get a reliable history from a man than from a woman, and sometimes it's a good idea to ask if you can speak to their partner or spouse and find out details of who they've been in recent contact with from them.